Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of February 3rd, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. Today, I'll provide an update on the pause in public health communications, go over the current status of respiratory infections, and provide an update on what is going on with tuberculosis. So I know we've been all hearing about the freeze or the pause on public health communications imposed by the current administration. And this was issued on January 21st by a memo from the Acting Secretary of the Department of Health and Human Services, Dr. Dorothy Fink. And I've linked the memo in the post in case you're interested in the details. But basically, this communications pause applies to all of the agencies that operate underneath the Department of Health and Human Services. So this includes the CDC, the FDA, the NIH, National Institutes of Health, and the basic premise of this memo is to ask all of the divisions to refrain from issuing any documents, any guidance, any notices, any communications, any social media updates, any website publications, any press releases, refrain from any public speaking, basically any communication at all until or unless it has been reviewed and approved by a presidential appointee. And this includes the Morbidity and Mortality Weekly Report, which is a report that I often review here on the briefing. It has been weekly for something like 60 years, and it's kind of a staple for public health communications. It, prior to now, has come out without fail every single Thursday, but for the last 2 Thursdays, there has been no MMWR report. As you can see, the last one was issued on January 16th. So it's not clear how long this will go on, but clearly it is in effect. Now, according to an article published in the Washington Post, there were 3 articles regarding H5N1 that were supposed to be published in the MMWR in January, so clearly those did not go out. And this definitely leaves a void, so we're definitely hopeful that this won't be for too long. The memo directed all of the things that I mentioned through February 1st, but then it's not clear if there have been additional instructions since then. So I'll definitely be checking on Thursday to see if there's a new issue of the MMWR. But I have to say that I'm going to be really trying not to side-eye the MMWR that comes out after this pause, because it says that nothing can be published without getting the approval of a political appointee. So it certainly makes you wonder what has been deleted, what has been sanitized, what has been added. And we know from experience of the early years of the pandemic about how documents were altered to make things sound less serious than they really were, or to accomplish other political goals. So while we know that the CDC is doing important work, important science, day in and day out, same with NIH, FDA, and all of them, the fact that they may be actively censored is definitely giving me pause. So I'll be looking forward to these important reports resuming, but I'll also be looking for other important sources of data and information that can help us to complete the picture. And this includes data from our states, data from other countries. And so we'll just want to make sure that we can get as full of a picture as possible, given some of the uncertainties. So as it relates to the regular respiratory virus reporting that we do here at the start of each briefing, what we see when we go to those pages is this advisory at the top of every single page that says CDC's website is being modified to comply with President Trump's executive orders. But the good news is that when we look at the data, it has actually been updated as we would have otherwise expected it to be updated. So that is good news. Hopefully this isn't just an oversight. Hopefully this is something that will continue uninterrupted. So let's go ahead and review. So taking a look at the weekly percent of tests that are positive for the various respiratory viruses that are being tracked in the National Virus Surveillance System. The story here is that several of these viruses are decreasing in terms of the share of positive tests. So rhinovirus, enterovirus, the common cold viruses, RSV in the green, SARS-CoV-2 in the red, human metapneumovirus there in the black. All of these, as we look at those lines from left to right, we can see that they're pretty much either coming down or they're kind of flat, staying the same. But it is the flu in the bright blue there that is increasing significantly. So if you take a look all the way over to the right, we can see that the blue line is the highest, that is at the top, that is influenza, making up the largest share of tests at this point. About 30% of the tests are currently influenza. And we can see that the second most common is that rhinovirus, enterovirus in the gray. That's only making up about 11% of the tests. And that's pretty far below what we're seeing with the flu. So quite a bit of flu out there and increasing, and it's making folks sick enough to go and get tested, or perhaps they're in the emergency room or in the hospital. So sick enough to be there and get tested. And this data is through January 25th. So as I noted, this is being updated. So that part is good news. Remember that we take this particular graph with a big grain of salt because we know that many people get sick and never get tested. We also know that we have COVID home tests. So presumably people who test positive at home are not going into the doctor for a test. So this graph is largely people who are sick enough to be hospitalized, go to the ER, or otherwise present for a test, or they don't know what they have, and so they go for a test. So it gives us a general sense of the direction of things, but it really represents only a subset of what is going on overall. Now, when we take a look at wastewater, this wasn't the news I was hoping to see this week. When we looked at it 2 weeks ago, everything was coming down in all the regions, but now it looks as though everything is actually heading up in just about all of the regions. The Northeast is coming up only very slightly, but everywhere else is heading up more significantly. We know that the gray shaded areas are still preliminary, but this is showing through January 25th, and it does appear to be going up. And to take a closer look at this, I will share my screen.
So taking a look here at epidemic trends across the United States, and remember this is using modeling to try to help give a picture of whether things are increasing or staying the same or decreasing at the state level. And so this is taking a look at COVID-19. And as we can see, a lot of the country in gray is not changing. So that is stable. But then we can see that in the purple colors, those are either likely growing or are definitely growing. So we can see that pretty much all of the West Coast is either likely growing or definitely growing in the case of Washington State. Texas is also growing, and also Georgia and Tennessee, and then all of these light purple colors also likely growing. So the only place it appears to be declining is in North Dakota, and then maybe declining in a few other states here. So this kind of helps give an idea of the direction things are going with COVID-19. And if we take a look at influenza, we can see that many more states are growing or likely growing as it relates to influenza. And that's kind of consistent with what we have already seen with the percentage of positive tests and what we'll take a look at now in terms of how that is actually impacting emergency department and hospitalizations and deaths.
And now taking a look at those big three viral respiratory illnesses, COVID, flu, and RSV, the ones that give us the biggest burden in terms of emergency department, hospitalizations, and deaths. So taking a look at emergency department visits here, we can see that influenza in the blue line, it has been heading straight up pretty much since January 11th. So from January 11th through January 25th, we're heading straight up. We'll just have to keep an eye to see what happens next. But this is looking pretty significant. And we can see here that the line got higher up even than it ever did for all of last winter. And these things do vary from year to year, so we'll just continue to keep an eye on this. But the COVID and the RSV and the orange and the purple lines do appear to still be coming down slightly. They're still around, but coming down. So that is good so far. And now taking a look at severe viral respiratory illnesses. So that's going to be our hospitalizations and our deaths. Looking first at hospitalizations, kind of similar picture here where around January 4th, things looked like they were trending down for everything. Flu, COVID, RSV, but then flu took a turn and started heading right back up around January 11th. So flu is definitely causing us some trouble right now, more so than the others. But when we take a look at deaths, we can see that this is deaths from all three viral respiratory illnesses. COVID is in the orange, influenza in the blue, RSV in the purple. Looking to the farthest over to the right, which are the most recent, those are in the gray shaded, so it's still preliminary, which means that they'll only go up from here as those death certificates come in. But right now we can see COVID is still causing more death than flu and RSV put together, although right now it's only slightly more, so it is getting closer, which we might expect to see sort of in the height of flu and RSV season. But if we want to take a closer look in at COVID deaths, we can see the week ending January 4th, there were 773 deaths that week. The next bar over is in gray, so we know that will definitely continue to increase because that's preliminary, but already at 831 deaths there for the week ending January 11th. And we know that that will go up, but it looks like we kind of reached the low point for deaths in late November, early December, with deaths in the mid 400s per week, so still a pretty significant number. And for the last 5 weeks, it just has gone up from there. So we will expect to see them coming down soon, since we've seen that cases, ER visits, and hospitalizations have been coming down, as we were just going over on those previous slides. And we know that deaths lag behind those indicators. So we'll be looking forward to seeing those come back down. But for now, over 800 deaths in 1 week from SARS-CoV-2 alone. This is too many. And we know that many of these can be prevented with up-to-date vaccination and timely antiviral treatment. So let's not forget that important prevention and intervention. And now briefly on the flu. As we've been reviewing here, flu activity remains high. It's increasing pretty much across the whole country. So far this season, there have been at least 20 million flu illnesses, 250,000 flu hospitalizations, and 11,000 deaths from flu. 47 of those are pediatric deaths. Reminder that everyone 6 months and up should get the annual flu vaccine. It's not too late. It's not just for elders. Our little ones in particular are pretty susceptible to severe illness. And these deaths in these children were by and large vaccine preventable deaths. So we really want to do what we can to prevent this from happening. And so let's not forget this important vaccine. It is definitely can be life-saving, particularly for those extremes of age, the younger and the older, but really it is recommended for everyone 6 months and up to also control the level of these outbreaks that we're getting and the volume of illness that we see overall, and to reduce the burden in terms of hospitalization and deaths as well. So we're still primarily dealing with influenza A, little bit of influenza B starting to pick up a little bit, and we're still seeing good susceptibility of these flu strains to the antivirals that we use. So remember, if you are at risk of a bad outcome, you get sick, it's very advisable to find out, is it SARS-CoV-2, is it flu? Because if it's one of those, then the sooner we get to it with antivirals, the better. So we want to get it diagnosed and treated as soon as possible, start those antivirals right away so that we can stop it from multiplying and stop you from getting sicker than necessary. And out of those, all those flu cases, we know that at least 67 of them are from H5N1. Of course, this is probably a major undercount since we don't necessarily get the specific flu types all the time. But we know that H5N1 is rampant throughout our cattle. It is rampant throughout our poultry here in the United States. And recently, we also heard about a human case of bird flu in the UK. So this person, similar to what we've been seeing for the most part here in the US, this individual contracted it on a farm where they had contact with infected birds. The UK is reporting no further transmission from that individual to anybody else. So we still have not seen human-to-human transmission that we know of yet. And that's definitely what we are hoping to avoid. UK has said that they are adding the H5 vaccine to their stockpile. Wasn't quite clear if that was for the poultry, vaccine for poultry, or the vaccine for humans. Haven't heard a lot about plans overall as it relates to that. So we'll definitely be keeping an eye on what is happening here to the extent that it is being shared. And also we'll be keeping an eye on what the UK is talking about, because clearly this H5N1 situation continues to progress, and it is progressing now into the UK. And we are still really seeing kind of an unmitigated situation as it relates to the spread in our cattle and our poultry. So the good news is still no human-to-human transmission. The bad news is we keep giving this virus ample opportunity to go from one species to another, develop new mutations, and the most feared situation would be that it adopts some mutations that allow it to spread easily from human to human. This is what we're hoping to avoid. But as we know, and as I always say, hope is not a strategy. We really need to hear our leaders tell us about what it is that we are doing exactly to prepare ourselves in the event that this occurs. So definitely looking forward to unfreezing of the public health communications and some reassurances that we're doing what needs to be done to protect ourselves, and not just ourselves, but the entire world, because at this point we are definitely propelling this particular situation forward with some of our agricultural practices. So now I want to talk about what is going on with tuberculosis. We've been seeing it a little bit in the news lately, so I want to share what we know. First, I'll just briefly go over some of the basics and give some broader context before diving into what we are seeing right now in this moment. So tuberculosis is caused by a bacterium, mostly by a bacterium, especially in the US, mostly by a bacterium caused by or called Mycobacterium tuberculosis. There is another strain, but the main one we see here is Mycobacterium tuberculosis, spread by the respiratory route and mostly affects the lungs, but definitely it can affect other organs, other parts of the body, like the spine. You can see spinal TB, you can see it in the brain, the kidneys. Now, not everyone who gets infected with TB will actually get sick. So we basically categorize TB into two categories: active TB and latent TB. And sometimes you will hear latent TB called inactive TB, but since it can become activated, I do think latent is a better word, because it's just laying around, latent, just sitting there, but it could become reactivated. But there is a huge difference between active TB and latent TB, so it's very important that we understand the distinction. So first off, just for reference, when we're looking at how many people in the United States have active TB, and we are concerned about increases, but we're really talking about kind of the range of like 9,000 to 10,000 active cases per year. And by contrast, when we look at latent TB, it's estimated that there are about 13 million people in the United States with latent TB. So worlds apart there. But the key is, or one of the key things is, that latent TB can become active TB, as I mentioned. And it is estimated that if not treated, about 1 in 10 of those with latent TB can become active TB. Remember, I said it's estimated about 13 million people have latent TB, so about 10% of those, if not treated, can actually get sick with active TB. So with latent TB, we have no symptoms, we are not contagious, so really you don't know if you have it unless you get screened. And when you get screened and you find out that you have latent TB, then you need to be treated with a pretty simple antibiotic regimen for a few months. There are different regimens, and it could be longer than a few months, but usually it's a pretty simple regimen for just a few months, so that we can treat the latent TB so that we really reduce that risk of it becoming activated. And it can turn into active TB if it's not treated. Particularly as you get older, or something's going on with your immune system for one reason or another, you could convert from latent to active TB. And that is, as I mentioned, about 1 in 10 people. Now, active TB described here on the right side is that you will have symptoms, and those symptoms can be pretty serious. We can see coughing and difficulty breathing, weight loss, night sweats. And if you have TB, you are contagious. Now, it's not COVID contagious, so it's not on that level where just a few minutes or even a couple of hours. It really is something that typically requires longer periods of time of contact, household contacts, typically congregate settings where you're spending longer periods of time with people. But we do spend long periods of time with people in school and at work and so on, which is yet another argument for excellent filtration in our schools and in our workplace and in just indoor settings in general. Because even though TB is not as contagious as COVID, it is more dangerous. It can cause quite a bit of sickness and a high fatality rate, especially if it's not treated. So we've been collecting data on TB cases in the United States since at least the 1950s. And here we're showing the past few decades, and we can see that since the early 90s all the way to 2020, we were making really great strides in bringing TB cases down. And this is looking at active TB cases. And we do have some of the lowest TB rates in the entire world. So this is really a credit to the incredible work that has been done in the United States to control TB. And this is mostly through a lot of screening, as well as treating those people who are carrying TB. So as well as treating all of those cases of latent TB. And I think most of us are familiar with the screening. We have the TB skin test that you would get placed in the inside of your forearm and check to see if it increases in size. And then we also now have blood tests, which are great. They're a little more specific. So we kind of like the blood test if we can, but it is more expensive. So we still do the skin test a lot. And sometimes we also have to do x-rays, but all of this screening has really helped us to keep things under control and help us ensure that we're identifying people with latent TB and getting them treated. And in addition to a lot of screening, we also report positives to public health agencies. And then there's a whole coordinated effort around identifying contacts, making sure they get treated and all of that. So yes, we have some of the lowest TB rates in the world, but of course there is work to be done, especially when you see something like this where things are heading in the wrong direction, which they've been doing since 2020. And I'm not sure we have a complete answer as to why cases started to go up after kind of being at an all-time low in 2020. Could be that the low in 2020 had to do with us not doing as much screening. But obviously we know what happened in 2020, so we can make some guesses as to the various factors that might be at play. But now we've gotten back to sort of pre-pandemic levels. We've been heading in the wrong direction for a few years now. And so this could be a combination of things, a reduction in all of the screening that we're talking about. Perhaps people with inactive or latent TB are left untreated. And so maybe there was sort of an accumulation of more people becoming with active TB. We know that TB can become activated when something affects the immune system. So could this be a direct result of some of the immune factors that are going on post-COVID infections? Could it be changes in travel and migration patterns? So these are all things that could contribute, kind of speculating a little bit here until we get some better data, better handle on it, and of course, see what's going on now. We need to see if this trend continues to hold or if we'll start to return to a better place, because it does take time for all these data to be finalized. So we don't have final numbers for 2024 yet. But from what we have seen, it did seem like we were on track to do as poorly as we did in 2023, but of course that still remains to be seen. So we'll report on that data when we have it. But what we have been hearing about more recently is an ongoing outbreak in the state of Kansas. And this is very concerning because we just really have not had that many TB outbreaks of significance in the last century or so, at least in the last several decades. In fact, there have only been 2 outbreaks that have been larger than this one in Kansas. And mind you, the one in Kansas is still ongoing, so it could certainly become larger than these other two that happened. But also the other two that happened were kind of special situations. One was in congregate setting, so in some shelters in Georgia, homeless shelters in Georgia, where there were more than 170 active cases. And that was from 2015 to 2017, so a 2-year outbreak. And the one in Kansas has been only going on for 1 year so far. So we'll just have to see how things go. Also in 2021, there was a nationwide outbreak. And that was linked to contaminated tissue that was used in bone marrow transplantation that affected 113 people. So I think that it's safe to say that those were particular situations and exceptional situations, and that hopefully particularly with this bone marrow situation, that our screening methods should prevent anything like this from ever happening again. Homeless shelter outbreaks, certainly very concerning, but we do know that congregate living settings are higher risk for outbreaks of this kind. So even though not Kansas City, even though the state of Kansas outbreaks may not be the largest in history, it's definitely among the most concerning because it's just sort of spreading through the community. So this is an outbreak with spread going on in 2 counties in Kansas. I put the link to the state public health department page on this outbreak. But it's been going on for about a year, as I mentioned. There are currently 79 active cases and 213 latent cases across the 2 counties. And it seems that things may be headed in the right direction, but this still is a major concern. There have been at least 2 deaths associated with this outbreak so far. And like I say, ongoing, so we'll have to see what happens next. Also, just in the past week or so, we've seen other advisories coming out of high schools, one in Michigan, one in San Diego, California. And this can be, of course, very scary for students and families and teachers and contractors and everyone else who may be potentially exposed, particularly frightening for people who are immunocompromised. They're otherwise at a much greater risk. And just scary in general, because after prolonged exposure to an active case, really anybody could get active TB. So what this means in these 2 situations is that there were active cases that were identified, 1 in each school. So those individuals will be isolated. They'll be treated with usually kind of a cocktail of several different anti-tuberculosis medications. These are usually needed for 9 months. This is kind of a prolonged, multiple medications, but it is treatable. And this will prevent the progression and reduce that what is otherwise a high risk of death when you don't treat active TB. So generally, these folks get pretty sick. They'll be isolated, and then there will be a whole response. So I can imagine right now at these schools that they're doing widespread screening. Anybody who comes up positive, their contacts will then be screened, folks in their households and so forth. So there typically are major efforts that would go into addressing a situation like this. But it is concerning because we are hearing now multiple cases of active TB in the United States. And I'll just take the opportunity to mention the obvious, which is that this is exactly the kind of situation where we'd want excellent communication and information exchange, such as health advisories, MMWR reports, and so forth. So the pause in communication is definitely adding more discomfort to this already concerning state of affairs. So this is clearly frightening and very disruptive, and there's a potential for severe illness in some. So what can be done? Well, I've gotten a few questions about the TB vaccination, which is called BCG. And those from other countries who've gotten it, many of you know it as the scar, a little round scar in the upper arm. And it is a TB vaccine that's given in many other parts of the world. It's given in areas where tuberculosis is common, and is typically given to infants and young children in those countries. And much like many of our other vaccines, its real benefit is preventing severe illness, particularly preventing severe illness in children. So the effectiveness of the BCG vaccine for adults is a little bit less clear, but is definitely beneficial in areas with a lot of TB and where we can prevent severe outcomes in children. And so we've been kind of talking about how the overall risk in the United States is low, at least for now, at least for some decades. And so for the general population, the benefit just does not seem to be there for mass vaccination. And that's mainly, again, because the risk of actually being exposed to TB is still really low. So even though the current situation is definitely concerning, and we're going to have to keep a close eye on it, unless you're in those counties, we're really not worried about a high risk of being exposed to tuberculosis. But I think the question comes up as this increases, if we see more of that, will that change? It could be that the guidelines could change. BCG vaccine is available in the United States. It's just not routinely given. It's in fact very rarely given. The other issue with the BCG vaccine is that it makes it so that our skin test that I was just talking about will come out positive. So that means that basically for the rest of your life after getting the BCG vaccine, you may have a false positive essentially on that skin test. And so in order to differentiate whether you really have TB or not, you'd have to either do the blood test or you'd have to go for the X-ray. So this now ends up turning to be a big hassle for people who've had the BCG vaccine. And as I mentioned, how it's not particularly effective for adult pulmonary tuberculosis. So as we're starting to talk about adults and whether to give it, it's not clear that it's going to provide a level of protection that would make it seem beneficial to actually mass vaccinate in this setting. So for those who out there who say that the United States just wants to push every vaccine on everyone for some kind of nefarious reasons, this is a great example that you can talk about of a vaccine that we have, yet we do not recommend it on population level. And the reasons or indications why we would even give BCG vaccine are very, very few and far between. And you may occasionally hear a situation where there's a TB strain that is resistant to multiple drugs. And then in that case, they may recommend the vaccine for healthcare workers in that setting. Definitely the exception and not the rule. So at this point, there's really nothing different that we need to do. There's no recommendation for the vaccine amongst adults or children at this point. We still feel like the risk of being exposed to TB is low, but we're going to have to keep an eye on it because the direction that things are going, we just need to keep an eye on it. But if you do live in any of these situations or places, counties, or have family in these schools where there have been active cases, then you're definitely going to want to pay close attention to your local health department guidance. I think one of the most important things to know is that it is treatable. And the biggest thing that you can do to prevent yourself from getting active TB is to find out if you have latent TB and if you do, get it treated. And that is going to be through screening that you would do at your primary care provider's office. So if you're one of those estimated 13 million people with latent TB, then getting screened, finding that out, and getting treated is the best thing you could do to prevent yourself from getting active TB. So this is really critical. Please address this with your primary care provider. If you don't have one, please get one. And let's continue to do what we can to keep ourselves and our loved ones safe and healthy. Please remember to eat a balanced diet, quit smoking, limit alcohol intake, avoid sugars, avoid processed foods and artificial ingredients. Remember to get some regular physical activity. If you don't feel well, then please do get your rest and get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. See you next Tuesday at 10 a.m.